we bring the latest technology using things like wearable technologies, remote monitoring, remote
Oh, yeah.
diagnostics, remote therapeutics, things like that. So they may be in Miami, so we'll ship them out. We have integrated digital stethoscopes. We have integrated spirometers of pulmonary function tests. And when the mother puts the stethoscope on the child's chest, switches it on, and I can sit here and actually I'll hear the lung sounds, the heart sound in live mode.
Wow. Welcome to another episode of the Doctors and Dollars podcast. I'm your host, Nate Crannell, joined today by Dr. Satya Hegde. He is a pediatric pulmonologist based out of Gainesville, Florida. He is here today to brush us with our knowledge, or his knowledge, of all things children, lungs, pulmonology. You are the first pulmonologist I've had, so I'm very excited to talk to you today. How are you?
I'm doing great. Thank you, Nate. I'm excited as well, and thank you for inviting me.
Tell me a little bit about yourself, because it's very curious to, we've had pediatricians. I know a pulmonologist, have not had him on here. How do you blend the two together? What was it? What event in the past, if there was one, that took you from maybe, hey, I really like working with kids, to the pulmonology side of things?
Yeah, good question. I went to medical school in India and had my initial grounding there. And at a time, and after my medical school graduation, I had to decide what specialty I wanted to go into. And it didn't take a lot of time. I actually debated between two specialties. One is pediatrics and orthopedics. These are two opposing fields. And then quickly decided on pediatrics because of the demographics of India, the mostly younger generation and a lot of kids. And also we had a lot of need for pediatricians. And from, social and economical standpoint, the job security was better in pediatrics as well. So there was a need that I could serve. That's why I did pediatrics. Now, coming into pediatric pulmonology, so I went to England after I finished my training in India, and had a good breadth of training in UK, which is quite different from the US. And I then wanted to become a pediatric pulmonologist for following reasons. One is, I didn't want to be a general pediatrician. I wanted to specialize in something. When I looked at different specialties, the pulmonology is a field. If you intervene early in childhood, you can really make a good positive impact in their later adult life. For example, things like COPD, and they all have their origins in childhood. Some of them even actually before they are born, but a lot of factors, the environmental and developmental factors that occur in childhood will influence their development into COPD. COPD can occur early, or it can be postponed, or can be totally avoided. That's one reason. And the other reason is lung is a fascinating organ. You may or may not realize it. There are only two organs that are directly exposed to the environment, to the changes in temperatures, pressure, or exposure to particles, then dust, pollen, things like that. The first one is skin. Skin is always exposed to the environment. Because skin is exposed to the environment, it has come up with a mechanism to protect itself. There's several layers of cells, and then the top layer becomes flat, called squamous layer, so that it's well protected. The next organ that is directly exposed to the environment, where it receives all the same parameters that skin receives, like temperature changes, weather changes, exposure to pollens, particles, things like that, is lungs. It has a huge surface area. And the surface area of the lungs, is equivalent to that of a small tennis field. You don't realize that. And the volume of the lung, when I say volume of the lung is made up of branching tubes like the branching trees, and they all end up in small bubbles or balloons called alveoli that's akin to the leaves on the trees, right?
Hmm.
If we could
Yes.
open all these alveoli, they're microscopic, okay, convert them into, let me say, a cloth, and then sew a bag out of the cloth, you know how big the bag would be? It'll be that of a small swimming pool.
Unbelievable.
So it's a large organ, a large surface area, a large volume in terms of a gas exchange, and it is exposed directly to the environment. And so it gets influenced by environment, the air that we breathe, and it processes that. And lung is also an immune organ. So because of that, it's a direct exposure. It is the entry point for, could be infections or inflammations from air pollutants, things like that. We don't realize. A person may be having cancer, for example, and have a chemotherapy. They're immunosuppressed. They're at risk of developing infection. Guess what? The point of entry, most common point of entry is going to be the lungs. So you
Yeah.
need pulmonology knowledge to deal with oncology, cardiology, various other organs. So that's
Yeah.
what actually took me to pulmonology. It's a fascinating subject. And you also have an opportunity to positively impact someone's
Absolutely.
life.
Was this something that you discovered in India? Was this discovered in London, where it's like, hey, as a pediatrician, if you're a general pediatrician, you may know the percentage better than anyone else would. It's like, how many are skin issues? How many are lung issues that you would be seeing, as a pediatrician? But then kind of that light bulb went off to be like, man, I'm seeing a lot of things related to the lungs and pulmonology as a general pediatrician. This has to be my calling. This has to be the specialty that I go towards.
Yeah, you got it. So I discovered it during my pediatrics. And again, one of the most common reason the parent would take a child to their pediatrician, other than well visits, with all immunizations,
Is a cough.
is a cough, runny nose, congestion, can't sleep well, all related to pulmonary. So pulmonary problem is the most common reason. Parents take their child to a pediatrician for sickness.
Absolutely.
It's the most
You,
common reason.
for sure. You mentioned a few other specialties, because it is kind of the pathway, the lungs are the pathway to all other things. I mean, you mentioned cardiology, oncology, which are you mentioned those words, and that has nothing to do with the lungs, or it can't be, unless it's lung cancer. But like, do you have to keep yourself up on the new trends, on the new treatments and things like that in other specialties, because of what you do is kind of layer number one, of a disease?
Yeah, good question. Fortunately, I don't have to because it's a real lot. I rely on we collaborate with those specialists very closely. For example, we get called to do a test called bronchoscopy on oncology patients. A lot. For example, patient with chemotherapy, they don't fever, they don't know the cause of infection. So often it's lungs, and we can do the lavage or the washings of the lungs and send for labs. We can take a look inside the lungs as well. So we get called frequently by like bone marrow transplant patients, for specialists or oncologists. We get called by cardiologists as well.
Take me one more layer into that. From a cardiology standpoint, what is that relationship between a cardiologist and a pulmonologist?
Yeah, it's a very intricate relationship in the sense we make an artificial distinction between heart and lungs, but heart and lungs work together. The function of the heart and lungs is to supply oxygen to the body and the tissues and eliminate carbon dioxide. That's all. And for that, the lung and heart cannot function in isolation.
Mm.
And they work very closely together. Okay. Now, coming to how exactly do I interact with cardiology, often there are diagnostic challenges, issues, and a patient or child may come with what is called low oxygen level. Okay, they may have some symptoms of coughing or shortness of breath. The shortness of breath can be seen from cardiac causes or pulmonary causes. Sometimes cough can be caused by cardiac causes as well. And so sometimes they end up in pulmonology, and then we work them up and we don't find a cause. We think it's cardiology. We send them to cardiology. Or sometimes they start in cardiology because they may also have some of the cardiac problem, congenital cardiac problem. And they have shortness of breath, and they don't think it's cardiac. They work with pulmonary, they send them to us. So we work closely together. And another area of collaboration is children develop what is called as congenital cardiac problems. So sometimes the heart is not formed correctly, and the left and right side could be reversed, or the arteries may take origin from wrong chambers, things like that. And under those circumstances, sometimes the arteries, when they take the wrong origin, they cause compression on the bronchi or the trachea, or sometimes they put what we call plumbing materials to connect the left side to the right side. They usually put an artificial, what's called conduits. Okay, they're pretty common in congenital heart disease. When they put those conduits, because it's what we call mediastinum, or where the heart and lung sits inside the chest cavity, is so crowded, and when you put that, they actually have to press on trachea or bronchi, and they leave an impression, and they sometimes cause problems. They cause coughing, wheezing, shortness of breath, sometimes cause collapse of the lungs, pneumonias, things like that. Then we go in, do a bronchoscopy, and we can find, hey, it's causing compression, so causing so much of compression, things like that. And then based on that, they can treat the child.
Yeah. So you're really seeing like the heaviest of the issues. Because you were saying that, those are obviously very severe. As you were saying it, I was like trying to picture if that happened to one of my kids, like the anxiety that would give me. So you're kind of seeing that upper level. So that kind of prompted another question: is what's the relationship between a general pediatrician and a pediatric pulmonologist? Like what's kind of that division of, hey, a pediatrician can handle up to this point. If something hits this line, anything beyond that needs to go to a pulmonologist. As we're speaking about the lungs, so somebody brings their kid in for difficulty breathing, or they have maybe really heavy congested lungs. What's kind of that limit that a pediatrician can handle until they're like, hey, I need to refer you on to a pulmonologist for your child's ailment?
Yeah, good question again. There is no sharp like a division beyond which they have to send the patient to a pulmonologist, or under which they can manage. So it really depends. It depends on, number one, the comfort of the pediatrician and their level of experience, expertise, and knowledge, and also what the patient wants. Sometimes it may be a case the pediatrician is able to handle, but the parents want referral to a specialist. That's also okay. So having that, what I would say a general statement, there are certain conditions where there is no doubt, most experts would agree that they're better handled by a pulmonologist. I'll give you some of those examples. For example, in asthma, in asthma, if you see a child who has been hospitalized for asthma, has been to emergency departments a few times, or a child who has had several courses of oral steroids for asthma. So these are the children who are categorized as either moderate persistent or severe persistent asthma. Those who need higher level of hospitalizations, emergency department visits, or oral steroid users, because that means the asthma is not very well controlled. Those children would be better served by an asthma specialist. An asthma specialist, when I say asthma specialist, allergists also see children with asthma. Pulmonologists will also see asthma. So either of them is okay to some extent. Some of the cases, pulmonologists can handle better, especially if we suspect airway issues, breathing tube issues, or even most severe forms of asthma. Especially if they've been to intensive care, they've been intubated, things like that.
What's like the easiest thing that you probably had to handle, where it was like, I will do it, but like maybe it was just a little bit of inexperience out of the pediatrician, or maybe it was a parent who was a little bit more hesitant to have their pediatrician handle it and they wanted a specialist, but really their pediatrician could handle it. So what's kind of the easiest thing you've done? And then tell me, like, what's the most complex thing where you walked away and wiped your brow and you're like, wow, that was intense. That was probably the toughest one I've done.
All right. So the easiest one would be someone who has a true asthma. They would have had a lot of symptoms, a child with a lot of coughing, wheezing, shortness of breath, and they're missing schools, and they're not being on what we call as standard therapy, which is inhaled steroids. We inhaled steroids them. And often they are just treated with what we call as needed therapy with albuterol. And so they would come and see us after having this problem for 6 months or 12 months. It's quite common. And then we do the testing. It shows everything is like perfect picture. Their lab test shows that they're probably allergic to something. And then the breathing test shows that they have some obstruction that gets better with albuterol. And then I go and put them on inhaled steroids and say, come back in 3 months. And their breathing tests are normal. Subjectively, they're feeling a lot better. They can participate in sports. So this is the easiest and I would say, happiest. The parents are also so grateful and they think, okay, I did something miracle. I did not do anything miracle, but this is the most easiest one.
Yeah, you just enforce the steroids. It's like, hey, this needs to happen. Do it consistently for 90 days and then come back. It's like, it's the old thing, like, hey, just take your medicine. Like, just
it works.
Get it done. Yep, it works. What's the most difficult?
Yeah, the difficult one is that often we encounter these patients, they looks like asthma, looks like a, certain diagnosis, then you put on the treatment and the treatment doesn't work. And then we have to go back and look, hey, whether the original diagnosis is correct, or could they have other complex problems, or could they have what is called therapy-resistant asthma or something else. And I can give you one specific example. And when I was practicing in Florida, Gainesville, a few years ago in Shands, so I encountered a patient who had, quote unquote, severe asthma, an adolescent female, had several hospitalizations, things like that. But when we did a breathing test, her breathing test results are normal, but she always had lots of steroids, things like that. So fast forward story, story evolved over time, and she was getting some headaches, some visual problems, and this and that. And it turned out to be a condition called histoplasmosis there. And how did we get to the diagnosis? And so over time, then we had to again go back to the boardroom and think, hey, she's not responding to treatment, standard treatment. Is it really asthma? Do we need to do and look at other things? Think out of the box. So that's what we did. She had a CT scan initially, and that was not bad. Then we had to repeat it. When we repeated, there were some abnormalities that on part of the lung that needed full investigation. And we did a lung biopsy. So I had to call a surgeon, thoracic surgeon.
Mm-hmm. Yeah.
They did a test called what is called thoracoscopy. That means small incision on the chest, plus a scope in which you can see the lungs and take a piece of the lung. And that clinched the diagnosis. And that actually showed that she had classical histoplasmosis. And the treatment for that would be entirely different.
Wow. So break down histoplasmosis for me. What is, those are like two separate words that they combined. What do those both mean to get to that? What's kind of the layman diagnosis for that? What does it mean?
Yeah, histoplasmosis is a is a condition involving a mold spore. Histoplasma is a mold or a fungus. That's very common in the Ohio Valley area, in Midwest. It was unheard of in Florida, and there was no reported cases in that area. So people, if I live in practice in Michigan, Ohio, and those states, along the Mississippi Valley or Ohio Valley, we see a lot of histoplasmas. So over 80% of the population, we inhale the spores from this fungus, and it doesn't cause any problem. We may have some mild cough, congestion, we may not realize, and it might leave a spot on the lung. For some reason, somebody gets a chest X-ray, it shows a spot of what we call calcification. And it's quite common, and it's what's called a burnt out in the past histoplasma. However, in small section of people, especially if they are immunocompromised, somebody who's on steroids for a long time, for whatever reason, or somebody who has a cancer, chemotherapy, bone marrow transplant, those are kind of people. If they encounter histoplasma, it can cause a lot of problem. It can invade into the body, the rest of the body. In a small section of people who are immunocompetent, they don't have any problems to affect the immune system, they can also have what we call invasive histoplasmosis. And this girl she didn't have cancer, she didn't have any other reason to suppress her immune system other than she had lots of courses of steroids to treat her asthma. She had a high dose of inhaled steroid that suppresses immune system, local immunity as well. So that's the only explanation that I have. And so if it's invasive, it can cause a lot of problems. It can affect different body organs.
Interesting. Did this patient experience anything else? I mean, other than the breathing and what they were deeming as severe asthma? And I guess you mentioned it earlier with the headaches and the distorted vision and things like that. It was kind of, it had to get to that point where, it's gone beyond pulmonology to other areas. That's where it really accelerated. And that's how you throw the word invasive in there, right? It really gets in there quick.
Yeah, we actually published this case. It's in the public domain as well, as in a journal, medical journal. And coming back to the other symptoms, headaches, and maybe he had some depression symptoms, things like that. It's very common in real life for a patient with asthma. Sometimes they also have a headache. It's very hard to sometimes decide whether they're all originated from the same underlying condition or they separate, because headache is common, anxiety is common, sometimes depression in our age is quite common. So they can have sometimes these different symptom complexes that are unrelated, or sometimes they could be arising from the same underlying condition. And an expert physician, a specialist, can actually help make that distinction, connect the dots.
Gotcha. What are some things that I wanted to say patients, but just general people can look out for? Because I know like mold, that's something you don't want to mess around with. So as a pulmonologist, that's probably like one of your biggest enemies is mold spores and things like that. What can people look out for? Is it wait until you get like kind of that chronic congestion and that cough to be like, hey, there might be something going on in my environment that my body's not agreeing with? Or is there something that they can look for, to be proactive before it gets to that point? And this could relate to mold. This could relate to, maybe it does go back to allergy, just going to get an allergy test. But how can people be proactive so that they don't get to the point where they become, a written case in a medical journal at some point in the future?
Yeah, I suggest use your good judgment, use your gut feeling. If your child is having some respiratory symptoms that you have to go to the doctors for, and you go to the doctors and it gets better, then probably you don't need to worry about it if it goes away. But if it goes and comes back, and it comes and doesn't go away for long, it could be a cough, for example, chronic cough, and it lasts more than 2-3 weeks after a viral infection, cough with mucus production that's again going on for a long time, shortness of breath. Any of these things, if they don't get better with regular treatment or they last long enough, I think you should consider requesting a specialist referral or seeing a specialist.
Gotcha. You've done a really good job so far of kind of breaking everything down into a more layman's term understanding of what it is, some of those major things that you're thinking of. It kind of segues me into the teaching that you do. I didn't find anywhere that you had been a professor or anything, and so if you have, let me know. But I saw that you offer your professional services to different universities, different state, healthcare systems, just providing, for the medical students, the resident physicians, those fellows that are going into that specialty training. You offer your services in that place. What attracted you to molding young minds, as it relates to your specialty?
Yeah. So up until 2019, I was always involved in a formal role as a teacher. I worked in medical schools as a full-time employed physician, where my role was I was appointed as an assistant professor. And I saw patients, but they also. Since then, I've been working as an independent contractor. In the same settings. I do the same job. It's just that I do not have a formal title as a professor in a medical school. Now, I do have actually a voluntary professor status at the University of Central Florida Medical School. And I'm being based in Gainesville. And even though, I could teach those students there, I'm not working in a hospital facility currently affiliated with University of Central Florida, but I work at other places. I worked in Albuquerque, New Mexico, working for the University of New Mexico, where I was a voluntary professor as well. And currently I'm working at a facility in Michigan. They have a medical school, residents, fellows, and medical students, all of them. So in my day-to-day work, it's no different than what I used to do when I was formally employed as a professor. So I round with residents every day, and it's a teaching round. And so we discuss about all topics relevant to that day's rounds. And same way, we have fellows in pediatric pulmonology, and sometimes they rotate through my patient assignment times. And we also have, every week, we have so many journal clubs or other teaching programs where I've given presentations myself or I participate with other team members.
Talk about the kind of that freedom you have then, because being, having that formal professor role to now being a contractor. So I'm assuming you went from a W-2 role to a 1099 role, kind of your own boss, right? And it allows you to have the flexibility not only in where you are in the country to teach, but also what you can teach. So I kind of saw you light up there. For the people who are listening on Spotify, they won't be able to see your face, but for those on YouTube, Dr. Hegde really lit up when he started talking about I got to explain things based on the day's rounds, and so every day is different. Is that something that really lights you up? As it relates to, hey, I'm a 1099 contractor who gets to decide where I go and how long I'm there and what it is that I'm teaching. Talk about that freedom.
Yes, I really, really enjoy my freedom and autonomy as a 1099 employee. And when I was full-time employee, I always found it difficult to what I would call maintain a balance between work and life. Work and life balance was very difficult. Not just from me, it's a general issue in healthcare that is causing a lot of burnout among physicians. It's a very commonly discussed topic these days. And in fact, that burnout and lack of ability to maintain autonomy and work-life balance is actually drove me to pursue this path that I have. It was not easy. Transition initially was not easy, but once, I found my independence, I am enjoying it so much. I have a 100% control over my work-life balance. And when I'm working, when I'm in an assignment, I'm 100% dedicated to work. So when I go and work, so my colleagues or other physicians are so happy because I'm always there. I'm able to provide that. When I was a W-2 employee, I was pulled in different directions and I had to answer to different bosses. And ultimately, I'm responsible for patient care, but I could not do that 100%. Now I can do that, but at the same time, when I'm off, I'm 100%, I'm off and I can do other things. And at work, I still get to enjoy working with residents, medical students, teaching because they are intellectually stimulating. That keeps you making you go back to read journals, update your knowledge, things like that. And along with that, I'm also able to pursue some research ideas. And to give you an example, when I was a full-time employee, I had a patent pending technology in pulmonology. It's an oscillation device to improve what we call as airway clearance. And that patent pending actually technology died. And we could not pursue it. Yes, had to abandon the position. On the other hand, when I became independent, I pursued another idea, and which is now patent pending, which is advancing. So the only difference here in this patent pending technology, which is a smart air quality monitor, I collaborated as an independent contractor. I collaborated with some researchers in the University of Florida and one person in University of North Carolina. So that led to discovering University of Florida, filed for patent. I'm one of the co-inventors, and I'm working with the University of Florida to license and commercialize this. And I'm the commercializing partner for them because I'm the only clinician. And, I can actually deploy that in my patient population or Access Pediatric. So that's quite exciting. And this technology, we were able to develop it, go long further than the previous one, which died. And we being an independent contractor, gave me that flexibility and independence to do that.
You're able to dedicate time to it, right?
Yes.
Whereas before you had to dedicate your time to the hospital system that you were at. That was really your only role versus being able to dip your toes in multiple things and creating your own time for each of those ventures. So you're right. You said it. That's very exciting to be able to get something from the patent pending standpoint. It's like, hey, I know this is going to move forward because I have the time to dedicate to it versus letting that patent pending die. That had to be a terrible feeling.
Yes. And along with not just the time, it's actually a decision making. From my end now, I am the decision maker. Whereas previously when I was employed, I was not the decision maker. It had to go through several layers of leadership, bureaucracy at the institution level. Now, because I'm the one who is main person for this, main anchor for this technology, even though I'm with the University of Florida, I'm the decision maker. It's much easier that way.
Yeah. Did you find yourself, and I've heard this from other, guests on this podcast, other physicians that I know in the professional world have said, I got to that point of burnout or the point of, is this really what I want to be doing? To once they did make that transition from a full-time hospital employee, W-2 income to now 1099 and having a lot more autonomy, that reinvigorated their love for what it is that they do and who it is that they're helping, and gave them more energy to go out and use the time that they now have to pursue other things. Did you feel that same boost of energy once you kind of made that leap from W-2 to 1099?
Absolutely. To give you one example, now to address the issue of burnout, hospitals and medical schools are bringing in various measures And one of them is they use a standardized tool. I think it's developed by, if I'm right, Harvard group. It's a questionnaire that captures the mental health of the overall health of the physicians to detect burnout and address burnout. And it's voluntary, so they are offering many hospital health systems are offering this. It's a confidential, what's a questionnaire you answer. Well, it basically measures if you are burned out or not. Okay?
Sure.
And you will still great. And then it gives you a score, and it gives you a compare how you compare with your peers in the same hospital or different hospitals. And when I was working for one of the health systems as a contractor, I got access to that tool as well. And it was not mandatory on the contractor, but I could do that. So I did the burnout survey tool. And guess what? When I completed the survey, everything was great. It gives you like a green, yellow, red zone and gives a score. And I had the highest happiness score
Nice.
among my peers and others. And because I have autonomy and my personal autonomy, work, pay, all those things.
Yeah, thank you for sharing that story. That paints the perfect picture of where I was trying to go with that. Just what it is that my business partner and I do on a professional level with wealth management and goal setting and things like that. We find that so many people have they've not progressed to where they want to be in professionally, personally, financially. They haven't got there, and a lot of it is because of where they are, as a W-2 employee, or the restriction that they have on what they can do professionally. And so then as they make the leap, they take that leap of faith that, hey, I can create the autonomy and I can still, support my family and do great things being a contractor now. Once they do that, man, the floodgates just open, and it allows them to do so many cool things that they never thought possible because they just believed, hey, it's residency, it's fellowship, it's you go work for a hospital system for 30 years, you save a little bit of money, and then you retire at a certain point in the future. And so seeing your face again light up as you talk about the different things that you're doing, you're exactly right. I know one thing that you're working on, still in the early stages, but it's going to be big, is Access Pediatric, right? You're the chief medical officer. What are some of the benefits that you have there, as it relates to telehealth and pediatric pulmonology? What is your role there, and how can that help? How can Access Pediatric help other physicians and patients?
Yeah, thank you for asking that question. So I'm also a co-founder at Access Pediatric. So
Awesome.
we are a telehealth solution for pediatric specialties. When I say telehealth, it's not the regular telehealth. We bring the latest technology using things like wearable technologies, remote monitoring, remote diagnostics, remote therapeutics, things like that. And when we combine all those together with our proprietary HIPAA compliant secure platform to bring in efficiency, to improve user experience, and also higher level of care to patients or pediatric patients at their homes or schools. So for example, we have integrated digital stethoscopes. We have integrated spirometers of pulmonary function tests. For example, in Gainesville, Florida now, if a child with asthma needs a pulmonary function test, their only option is to go to the local university medical center, and it's a hospital-based procedure. You have to get an appointment, do all those things, right? Now, patient access care through Access Pediatric will send them a kit, and the kit will include a digital stethoscope, digital and all connected pulse oximeter, a spirometer, or a pulmonary function measuring. So they may be in Miami, so we'll ship them out. And we have dedicated what we call care valets, virtual valets. So they come online, they'll help them to teach the parents how to use the equipment. And
Very
that
cool.
they'll download an app in their iPhone or iPad or whatever. And these devices are all connected to that. And when the mother puts the stethoscope on the child's chest, switches it on, And I can sit here and actually I'll hear the lung sounds, the heart sound in live mode.
Wow.
Okay. And then we can also, they pull out the spirometer for the pulmonary function testing. And we teach them how to use it. They blow into that. And I get the results here. It's the same kind of results for which they have to go to a major hospital.
That's unbelievable. I mean, I thought we were cool. So my son had some lung issues right after birth that put us in the NICU for 6 days after he was born. And then anytime he gets really heavy chest congestion, it hits him a little bit harder than our other kids, and you can tell that. I mean, so we have the aspirator thing. We have a pulse ox that goes on his finger.
Yes.
And I thought we were cool because a lot of other families are like, oh, hey, can we borrow that? Like my kids, I want to be able to check their oxygen levels while my kid's sick, and so we had one at home, and I thought that was pretty cool. But you've taken it to the next level with Access Pediatric and having all of these different tests linked to the Wi-Fi of a mother's phone or iPad, and then you can. I don't know if I heard you say in real time, but at least sending those readings to you guys without you having to be in Miami or for me to be in Iowa. I mean, you guys can read all of that from Florida. That's fantastic.
Yes, in real time, and goes directly into the patient's child electronic health records and becomes part of that, or, they want to send a recording and send, because sometimes at nighttime they hear some sounds and it's not emergent. They don't have to take a checkup. So they can use these devices to record it and send it to the doctor for review next morning.
That is incredible. Well, last thing I want to ask you about this, because I want to be respectful of your time, is what's next? What's like, you've gotten to this point, which is, I'm already impressed if you can't hear it in my voice. What's kind of that next thing that would really wow people? Because I know asthma and lung function issues are very prevalent around the whole country. Like, what's the next big thing that people should be looking for?
So the next big thing is the healthcare is changing rapidly. They're going to see a adaptation of a lot of these devices, wearable devices, and they're all connected. They're going to see newer type of devices as well. And recently at a conference, I heard that Samsung will be releasing a watch the fall, and that has FDA approved to monitor sleep apnea. So you wear the watch, and it can actually, not only based on just the pulse oximeter signals, it can do a lot of other analysis for which you need to go to a sleep lab to get sleep. As FDA, it's quite astonishing. And so, if I want to do a sleep study on a patient who may have sleep apnea, I can just tap into that Samsung watch, or there are certain FDA approved specialist watches as well we can send out. So these are the kind of things you're going to see in the coming years. And with regards to what I'm doing, I mentioned to you about a patent pending smart air quality monitor. Okay? Mm-hmm. So we're trying to commercialize it, build a prototype. So that smart air quality monitor will act as a carrying case for inhalers, people with asthma, inhalers. Mm-hmm. So if you have a patient or a child with asthma who gets a lot of asthma attacks, and the asthma attacks occur from triggers in what you breathe. It could be a pollen or allergen or an air pollutant or a exhaust gas from vehicles, things like that. And there are different components. And this air quality monitors continuously measures temperature, humidity, nitrogen dioxide, dioxide, sulfur dioxide, nitric oxide, volatile organic compounds, things like that. It has various sensors. And it measures in the immediate vicinity because it's portable. Somebody with asthma, they always carry their inhalers. And this acts as a carrying case. That means whether they're in school, whether at home, bedroom. Currently, we don't have the capability to measure these potential triggers continuously. Now, the idea is once this technology is adopted, if I have 1,000 people with asthma using this, their individual triggers might be different. So by monitoring it and using artificial intelligence, big data, it can come up with an actionable intelligence for individualized, personalized care. I can say for this person with asthma, it could be a combination of pollens plus PM 2.5 particle, for example. For someone else, it could be just the nitric. So we'll be able to pinpoint, and we'll be able to predict and forecast their asthma exacerbation and act quite early on.
All right. Well, now you prompted one more question because now I'm super curious. So is this, because people in the past have carried their inhalers around, and you're saying now there's a device, an air quality device that people will be able to carry around. Two-part question. One part is this being worn on their person in some way, or can could a young person carry this in their pocket? Could an older person carry this in a purse or something like that? So is it wearable? And then part two, is there going to be some type of way to say, okay, there is 10,000 people that are wearing this thing in Southeast United States, and we can tell regionally, okay, people up in this area, they have higher levels of nitric oxide that, in this certain region. Down here, we can see that there's more pollens, and that there's ways to then counteract that and be more proactive on how to treat, to say, okay, people in South Georgia and South Alabama, there's a higher pollen level here. Let's treat it this way, versus there's a ton of nitric oxide up in North Carolina, and we can track it regionally what people are getting from these devices.
Yes, thank you. To your first part question.
Sorry, that was really long.
No, it's okay. First part question, whether they can carry it on their wearable, or they can carry it as a device in their purse, things like that. So the one that we are proposing to build, our patent pending device, we don't have the device yet. It's a prototype stage, so it's not available in the market yet.
Mm-hmm.
And on the other hand, there are portable air quality monitors that you can buy on Amazon or other stores, and what some of them measure, some parameters, or they measure other parameters. So you don't have one device that measures all the relevant respiratory parameters relevant to respiratory health, all of them. Okay, we don't have that. Now, once this becomes available, so this is not a wearable device. This will be a device that will be attached to the inhaler. That means people carry their inhalers in their pocket or in their backpack. So they can carry it in their backpacks. So whenever they carry the backpack, it measures the air quality there. Now, to your second part question, hey, there are people using this all in different places. Can we map them out? Can we create a map of these triggers? In some areas, it could be one trigger, in some area, other trigger. Absolutely, yes. And we already have some of those systems, but they are not high fidelity. If you look at the weather map, for example, it does give you pollen count.
Mm-hmm.
Weather map. And so where does that data come from, pollen count? It comes from, some of the larger cities they will have one monitoring station, okay, and that could be like 30 miles away from where the population lives, for example. And that monitoring station monitors all this data, and that's sent to the central server. Mm-hmm. And there'll be a lot of regional variations within the same city, different zip code wise. And then there'll be variation between morning, afternoon, and nighttime. So the current existing systems, they cannot differentiate that.
Yeah, it's a little archaic.
The one that we have, yes, will have higher resolution, temporal, time-wise, day-wise, zip code-wise, etc.
That's awesome. Yeah, to say someone that lives 30 minutes outside of the city in the morning is experiencing a certain pollen count. And then obviously there's winds and things like that someone in the city mid-afternoon is then,
Correct.
Getting that same pollen count. You can kind of see that flow and movement and understand how that all coordinates together. Well, Dr. Hegde, this has been awesome. I always try and learn something new with every person that I meet on this podcast, and you have exceeded my expectations. So I want to thank you for that. Thank you for taking the time, out of your busy schedule to hang out with me. And I certainly look forward to our paths crossing at some point in the future.
Thank you, Nick. It's been a pleasure and an honor.